My name is Selin Sagalowsky. I currently serve as Vice Chair for Education in the Department of Emergency Medicine at the NYU Grossman School of Medicine. So clinically PEDS to PEM trained, and previously before this role was the Fellowship Director here at NYU, and prior to that did a lot of work in undergraduate medical education with the Pediatric clerkship over at Columbia before coming to NYU. There are so many applications for AI, and we're in, the boom of the hype cycle in many ways, and really like across clinical, educational, and research domains. I personally have the great benefit here at NYU of being part of the Precision MedEd laboratory of the Institute for Innovations in Medical Education. So many folks listening will be familiar with the work of our director, Mark Triola, our assistant director, Jesse Burke-Raffel, who really sort of helped lead the IAME and all of the sort of amazing folks and collaborators therein. And so my recent work and excitement really centers on leveraging AI and educational informatics for precision education through some of this, this network. And I think for PEM especially, I think all of us know that we practice in a high stakes, low frequency field as generalists. And the central question in education, or one of the central questions that we've always faced, is really, how do we know that our graduates are ready for independent practice? Have they had the exposure, the experience? Do they have the competency in really the breadth and depth of clinical encounters that we see and will see in PEM, or at least of the core clinical encounters, right? Like as generalists, you can never know everything about everything, but have you mastered the core content? And GME education really relies on experiential learning and the apprenticeship model. And we put people in at the front end, we take them out at the back end, and we develop our program of assessment in between to try and ensure this. But really, what you see clinically has often been a black box before the informatics age. And people have been trying to capture this data for, longer than we've been alive, initially through, manual self-reported patient or procedural logs. And then with the informatics boom through the EHR, looking to extract automated data and metrics from this vast EHR repository to be able to say, what are you seeing, what are you doing in the clinical space beyond direct observation? And many of our colleagues have done this. I think of Josh Nagler and Rich Bacher, Kristen Loftus, Jonathan Levin, and John Rohn really put out some of the foundational educational literature looking to capture this in our clinical field. And also, obviously, to not just see the EHR data, but to provide or feedback that data using something that's really an educationally meaningful taxonomy. Here at the IAME, folks outside of PEM, so our colleagues in internal medicine, specifically Dan Sartori, David Rhee, have looked at doing this or have done it in their field in internal medicine, extracting ICD-10 codes, mapping it to categories within the American Board of Internal Medicine, and using that to drive individualized learning, curricular change, programmatic assessment. But all of that is still manual, right? And so one of the projects that I'm most excited about, we're collaborating with, sort of a multi-specialty project to automate this, leveraging AI and large language models. So this work is supported by a grant from the American Board of Medical Specialties and is led by one of our former informatics fellows and now informatics associate program director for the fellowship, Kiran Malhotra, in partnership with our clinical informaticist, Nick Jeans, and a whole team from IAME and also from our MCIT department. And the idea is that we could leverage large language models and AI through publicly available tools and really craft prompts that extract ICD-10 codes and automate matching them to content categories that are educationally meaningful. We piloted this in EM using ABEM categories, and now we're doing it for PEM using a combination taxonomy that takes from both ABEM and the ABP, and saying this way we can display this data for learners, for program directors, for educators, so that you have a snapshot on an interactive, personalized dashboard that feeds you back clinical data on exactly the content that you've been exposed to in the course of your clinical training. So GI cases, of those GI cases, how many were obstruction? How many of those obstructions were ileus and intussusception? And the beauty is that once you have the basic foundation for this kind of dashboard or data extraction, you can then also link that to, patient care outcomes and learning outcomes. And so we think about, the work on educationally sensitive patient outcomes or tracers or residency sensitive quality metrics, some of the work that Dan Schumacher has done. And we have those clinical performance metrics ready too. And now all of a sudden you have the capacity through educational informatics to actually correlate what you do educationally, what you see educationally in the clinical space through boots on the ground training with hopefully competency-based and patient-centered outcomes. And that's really the holy grail. We're not there yet. And our goal was to do this across multiple specialties. So we're looking at EM, PEM, and optho as a pilot, and to really be able to provide a model that can be adapted to other programs, other institutions, even other specialties, to be able to build similar, feedback models. And ICD-10 codes are imperfect. You can, we're currently picking one, your primary ICD-10 code, which obviously misses like a whole bunch of capture for educationally meaningful data. But once you have a basic groundwork for this, you can leverage LLMs to look at better information from the EHR, right? Medical decision-making, assessment and plans, order entries, to fully capture or to curate what you're seeing in a more impactful way down the road, hopefully. Yeah, I'm not an informaticist. And in fact, I often enter these talks with the caveat that I'm somewhat of a Luddite. Like I'm definitely a little, tend to be, I haven't been in this realm, but tend to be somewhat a late adapter or skeptic of technology. I tend to be sort of late on the hype cycle. But I have fully embraced and have come to realize some of the like ego tempering or the hubris necessary to like fully embrace that AI does things better than us because it has all of the data in the world. And that data might be flawed. It's only as perfect as the people who put out that data or the systems that put out that data. But we're at the point where like the evidence really shows that AI is more accurate than humans at, differential diagnoses, at suggesting management plans. It can triage patients with similar accuracy to humans. Even might be perceived as more empathetic by patients, according to many studies. And so I do think like the holy grail is really an AI co-pilot that continuously interacts with us in the clinical space for clinical decision support, for identifying high-risk conditions, prompting diagnostic and management changes or decision-making, providing real-time feedback through both ambient audio and ambient video technology. I mean, the AI tools will be baked into, I think, everything we do clinically eventually. I think that's going to be very impactful and obviously comes with, a lot of safety validity considerations. It's going to take a lot of sort of research and data to get to that point. But to me, that's the holy grail. Again, a little bit outside of my scope of, expertise or practice, but it's almost here. I mean, there's so many again, but again, if I'm going to put on what my passion is and put on my educator hat, I think one thing that preoccupies me and makes me feel like we're the ones who have to drive this ship all together, we being clinician educators, boots on the ground practitioners, folks who are teaching our students and our trainees, is really sort of this risk of de-skilling or never skilling or mis-skilling as we think about relying on a technology that might be flawed, but even if the technology is perfect, what does that mean for our human capacity and for our professional identity? And also just for our psychological safety. If AI is not just with you for decision making at every step of the point, but watching you and giving feedback, suddenly you're operating constantly under a watchful eye. And what does that mean for who we are as people? I think, this has received a lot of discourse and attention lately, both within and outside of medical education. I think about the nice recent publication by Raja Ali Abdul Noor out of Harvard looking at educational strategies for clinical supervision of, AI use. And I do think it is a real concern, but it's not one that's unprecedented. I think about, the calculator analogy, which sounds very rudimentary, but it's not that rudimentary, or even just internet, right? And so we've had really sort of groundbreaking tools or technologies come to the fore before. for our children, you think about, for those of us who are parents, yes, there's certainly been some de-skilling in basic mathematics, right? The kids cannot do long division in their heads anymore. But what is the balancing measure for that when calculators are universally available? They can still do foundational numeracy because there's been intentional education around that. Calculators are not permitted in your early foundational mathematics classes. Even when they're introduced in use in elementary school, there are spaces where you can use them and where you can't use them. There's some foundational work where you have to demonstrate competence before you're allowed to utilize a calculator for more advanced calculations. And then it frees up creativity and space and skill to do more advanced mathematics in a way that you could never do relying on your brain alone. So I actually think the calculator is a nice analogy for something like AI. And we know that there is changes in the brain when you rely on these. There, was the recent MIT study, which, by the way, is like 120 pages. So I don't know who's read it in its full, but on what happens to the brain when given tasks, sort of using brain-only groups, search engine groups, or LLM-assisted groups. And we know that those have the overall weakest neuronal coupling when you rely on large language models and AI. It reminds me of the old London cabbie taxi driver studies who either had to drive around with no Google Maps or Quest or whatever it was at the time versus those who did, and the changes in the hippocampus for folks who relied on spatial memory versus those who didn't. The balancing measure in all of these studies is that when one area of the brain sort of gets weaker from relying on technology, another area of the brain maybe gets stronger. This was shown in those London cabbie studies. And so I think when I think about how we start leveraging these tools for all of these things, feedback, clinical decision support, diagnostics, management decisions, the question becomes, how do we continue to cultivate conceptual, deep understanding so that we remain adaptive experts in our field? And what does it fundamentally mean to be a physician? And, I firmly believe that we have to maintain those skills. We cannot rely 100% on AI to just do our jobs for us. First of all, because that's impractical. It won't be everywhere. But also because AI cannot forward think to things that have never been seen. It can only use data of what has existed in the world and repackage it and give advice or make predictions on that. The idea of adaptive expertise is being able to use your expertise to adapt to novel, unforeseen situations, because that's what messy human life is. And we know what strategies are needed for that. You need good productive struggle. You have to introduce learners to desirable difficulties. You need deliberate practice and meaningful variation. And you have to engage in some degree of reflective practice or metacognition. And so I don't have the answers. I've sort of brainstormed, we've talked with other educators and other forums through different consortiums of, what does this mean? What are some practical things we can say to help maintain the safety and efficacy of AI for our professional identity and for our learning? And so I've sort of boiled it down to my cute catchphrase of 5 focused fundamentals. One is sort of delayed use. So to be intentional about when you allow learners to introduce the use of AI. And that comes back to this sort of foundational numeracy argument. Even something as basic as, in our shop right now, we've started with Abridge ambient scribing. And this gives you sort of, for faculty, some medical decision-making and assessment and plan and auto prompts, and generates, using AI, some of this diagnostic clinical decision support as part of the technology. Even just a simple question as at what stage do we allow our trainees to use this feature, right? That sounds like a simple question, but it is a foundational, fundamental, existential question. And so being intentional about that. The other is preserving some sacred spaces, just like the calculator is not allowed in all tests or all homework assignments or all classrooms, to preserve some sacred technology-free spaces or digital diets for learning, where you have that neuronal coding of 3D stimulation, tactile learning, writing on a board, looking at people in the face. And that doesn't have to be 100%. There are benefits and downsides to digital learning too. But at least, intentionally inserting those sacred spaces. And then when we're using AI, making sure that we are taught and teach each other and learn how to have smart prompts and how to validate the output, because the veracity of what we're using still depends on us. We still have to have a gold standard to compare it to. We still have to know that what it's telling us is true. And then lastly is to think of AI as an intelligent tutor rather than an answer box. If we're just constantly using it to give us our medical decision-making, our diagnostic plans, our management plans, we're no longer physicians. you can construct all of these decision support tools in a way that have Socratic method embedded in them, especially for trainees and learners. Maybe once you have adaptive expertise, you don't need that anymore. It doesn't have to be a tutor or prompt based. You can use it for routine diagnostics and management and rely on it, but especially in the early stages to rephrase it as an intelligent tutor. So again, these are not hard, fast rules. They're sort of strategies that I think we have thought of to think, how do we safeguard against some of these things that might threaten the safety and efficacy of AI in not just clinical practice, but in medical education. That's where I've come so far. But it's a challenge, and every day is something new, and it's hard to keep up, because just when you think you have a path forward, or you want to investigate something or study the impact of something, it just rolls out so quickly. And so some of this is also going to be, you don't want to have analysis paralysis, but being intentional in sort of the implementation science of these tools, and really thinking about how are we measuring the balancing effects. Happy to chat with anyone who might be interested or looking to collaborate. I know we have a number of folks who are doing a lot of similar work to what I've described and what we're doing here at NYU across the country and across the world, who are really also leaders in this field.